Thank you. Good luck to everyone.
So hi everyone, and welcome to today's Journal Club. I'd like to thank IJGCS and ESGO for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. If you are having any difficulties or questions, please send a message in chat and our technical support will assist. We'll have time for Q&A and encourage you to submit questions via the chat function throughout today's session. And with that, I'm happy to hand it over to Dr. Rene Pareja.
Thank you, Arthur, for introduction. Hi, everyone. It is my pleasure to be here. Welcome, all of you. This month's lead article is Uterine Transposition for Fertility and Ovarian Function Preservation After Radiotherapy by Dr. Reitan Ribeiro from Hospital Erasto Garner in Curitiba, Brazil. I'm pleased to welcome him to join us. Reitan, thank you for being with us today and sharing a deeper insight into this great article. I'm going to hand it over to you for a summation of the article.
So thank you so much, Rene, and thank you for ESGO and IJGC for this opportunity. It's an honor to join you today and speak a little bit more about uterine transposition. So we can start sharing the presentation. So this study started in 2017, and the idea was to evaluate if uterine transposition was a feasible procedure to preserve uterine and ovarian function. So we wanted to make sure we could start from somewhere and make sure we were going to do something safe and feasible. So next slide, please. So what we know now, where do we start? We know that pelvic cancer frequently need pelvic radiation as part of the treatment. And we know that radiation causes ovarian failure even in low doses. But it's very important to understand that it's not just ovarian failure. You have all the uterine myofibrosis, you have the endometrium damage, vascular damage. And so those uteruses are not capable of carrying spontaneous pregnancy and healthy pregnancies. So it's very important to preserve also the uterine function, meaning the capability of getting pregnant and delivering a baby. So the objective of the trial was to evaluate this capability of preserving the uterus more than preserving fertility. And the point is, why not fertility? Because you need more patients, you need more time. So we wanted to start with something that could be measured, and it was like menses, hormonal function, and all that. So that's why this is a small trial, and more to evaluate function than specifically pregnancies. But we also evaluate pregnancies, complications, surgical complications, and other factors involved with the procedure. So we started this prospective trial, multicentric trial in June 2017, and we were allowed to select patients until June 2019. Next, please. So what are the main results? After having 8 patients accepted to participate in the trial, 1 patient lost the uterus because of uterine necrosis. This patient did not lose both ovaries. She lost one of the ovaries, and the other one we managed to keep. So she has normal function until now, hormonal function, but she has no condition of having pregnancy. Another patient died 4 months after transposing the uterus to the upper abdomen because of carcinomatosis. So before being able to try to put her uterus back to the pelvis, she died from cancer. So a very serious cancer, very really bad evolution. The other 6 patients managed to keep the ovaries and the uterus. They have normal menses, they have normal hormonal function, and 3 of those patients tried to get pregnant. One of them tried even with 3 IVFs, in vitro fertilization, and she didn't manage to. But the other 2 patients who tried to get pregnant got spontaneously pregnant. They had like normal pregnancies and healthy babies after 37 and 38 weeks. Next, please. So this is just to give you a full picture of the trial. How do we evaluate those hormonal function and uterine function? So we decide to use menses as a way of measuring uterine function, and all the patients have regular menses. And this is very important because if in less than 1 year, one of those patients stopped having regular menses or did not have hormonal function, they would be considered not a successful case. So they would be considered that we didn't manage to preserve their function. So hormonal function and menses were very important to us. Another thing is that we realize that some patients, they have complication. The most common complication was cervical ischemia. So you have to be careful, because usually that's not a major complication. You can manage that. And we realize that by ischemic signs at the cervix, like this blue color or not a very good perfusion, and usually they develop this stenosis, but you can easily treat it with dilatation and very simple maneuvers. So all those patients, after simple maneuvers at the time of reimplantation, they managed to have normal menses and normal hormonal function. So this is something that we also saw it in the early cases. So in the first probably 4 cases, we had the ischemia, the ischemic cervix, and afterwards we didn't have it anymore. So it's related to some technical aspects. We can comment on that later. But I think in the end, the most important thing is we have in the literature 5 cases, reported cases of women who got pelvic radiation and got pregnant. And well, now we have 7, actually 8 cases. So, and 3 of them are with this recent technique, which is uterine transposition. So in less than 3 years, we have more reports of pregnancies and deliveries than for the last 50 years of traditional treatment. So this is, I think, it's the main outcome of the procedure. Next. So this is a compilation of the data. So 8 cases, actually we recruited 11 patients. 3 of them did not accept to join the trial, so we include 8 patients. 1 uterine necrosis, 1 patient died from cancer, 6 patients we managed to have full preservation, and 2 of them have babies. So in conclusion, we think that uterine transposition, it's a feasible procedure to preserve gonadal and uterine function in patients recurring pelvic radiation for non-gynecological cancers, preserving their capability of getting spontaneously pregnant and have successful deliveries. Next.
Okay. Do you have another slide?
I think that's the last one.
Okay, Reitan, thank you very much on a nice and impressive description of your article.
Thank you.
We will now spend the remaining time on answering questions and group discussions. Attendees, we encourage you to submit questions via the chat function, and we'll do our best to address as many as possible. We're going to start out with some questions by our fellows, but the first question will be done by Arthur. Arthur, can you proceed, please?
Yes, thank you so much, Rene. Thank you so much, Dr. Ribeiro, for your excellent presentation. And I just have one question. So one patient with rectal cancer died of carcinomatosis 4 months after uterine transposition. Do you think that surgery for uterine transposition prior to radiotherapy as primary treatment for non-GYN cancer could potentially cause a peritoneal spread of tumor in the abdomen? Yeah, thank you.
Yeah, probably this is one of the central questions about the procedure, is how the procedure can affect survival of those patients. And we are quite comfortable to say that probably it's not related to procedure itself, because we are doing ovarian transpositions for those patients for more than 30 years now. And there are many papers saying that ovarian transposition is safe. So it's fair to think that uterine transposition doesn't add too much to the procedure at the point that we would say that it was the cause of the bad evolution of this particular case. I think this is more something of related to the nature of the disease itself. However, we have to keep in mind that this may happen, and we need to keep the surveillance to see after, when we have more cases, larger number of patients, we may have be more confident to say that it's not related. Until now, it's probably not related to the surgery itself.
Right, but anyway, those patients are patients with locally advanced rectal cancer that have a natural history and a proper behavior. So we need to be careful when selecting the patient, but we are going to miss some patients due to disease, most likely.
Yeah. It's very likely, and actually that's something that we discuss with the patients prior to the procedure, that they may have a recurrence, and so that's why we usually ask them to wait for 2 years before trying to get pregnant. It doesn't work actually, because when patients decide to get pregnant, like we say in Brazil, you cannot stop a patient who really wants to get pregnant.
Perfect. Thank you very much, Reitan, for your answer. Luigi, do you have a question for Reitan?
Yes. First of all, thank you, Dr. Ribeiro, for your fantastic study. And based on this study, I suppose that many oncological centers worldwide might be interested in implementing this procedure or to start some pilot studies on this topic. So what would you suggest to these centers? And also, since you are collecting data on this topic, would you allow new centers to join your study? Thank you.
So, yeah, that would be great, because we have a study, the study in Brazil, we got an extension, so we can keep doing it until 2030. So we have 7 years more to work on the cases. Obviously, it will depend on each country, that they have their own regulations. And what we are working now is, if you are in a center from Brazil, it's very easy to join the trial. We just request, and they just add a new center. So it's very easy if you're inside Brazil. And the other countries will depend. Some countries use other countries' regulation, and if the other country has an approval, it can easily start doing it. But most of the countries will ask for a specific trial in the country or a specific approval. So what we are doing now is we are working in an international protocol that could be easily adopted by other countries. I think that's the easiest way now. And I believe that we are at the point that you don't need to join our trial specifically, but you can start your own prospective evaluation in your center. So I think that's way easier. And then we can put all together in the same platform and collect data prospectively. But considering each center may have their own prospective data, probably that's the easiest way, because we will need lots of centers, because this is such an uncommon surgery that if you want to get large numbers, we have to make it very easy to all centers who are interested to do it. And we also have this discussion within our group, is when uterine transposition stop being something experimental and start being something that you can offer to all patients. And we have some disagreement. And actually, I'm probably one of the more conservative guys in the group. And some people believe that, okay, that's enough. We now have enough data because you don't have other options. You don't have other good options for those patients. I know rich countries, you may have access to IVF, but most of the countries, they don't. So especially for those countries, they may go direct and start doing the procedure.
Perfect. Thank you very much, Reitan. We have a question from one of the attendants. There is congratulating you. Thanks for your great work. In the letter, I reported other techniques to preserve uterine function, such as round ligament suspension or uterine ventral fixation. Do you think that the transposition is always the best displacement technique, or it can be tailored according to the radiation dose that is supposed to be received by the uterus?
Yeah, that's I think one of the greatest thing about uterine transposition that's that it brought light back to something that people were not looking anymore. And I'm quite sure that there will be other options for those patients and not just uterine transposition. And I think that ventral fixation, which is like taking the uterus to the abdominal wall or suturing the uterus to the abdominal wall, may be a really good option for maybe lots of cases, maybe more than uterine transposition. We need more studies about that, so we're still working on something that we don't have data, but it probably will work, especially now with more advanced radiation techniques. So you may not need a uterine transposition, for instance, for a canal carcinoma. Maybe you manage to do it without a uterine transposition, just ventral fixation. But there are lots of questions that need to be answered before saying that's a feasible and safe procedure. Another thing about a ventral fixation is most of the cases, unless you may correct me if I'm saying something wrong, but you have to do an ovarian transposition. So you have to detach the ovaries from the uterus. So in the end, you will need IVF for those patients. So you need in vitro fertilization for those patients. So it's gonna exclude like half of the world of this maybe 70% of the world of having access to IVF, because usually those patients, they don't get pregnant spontaneously. You need some IVF, some sort of IVF. So and I think that's one of the points we have to discuss. So probably, and I hope we will have 3 or 4 different procedures that will allow those patients, and you can pick one of them as an option.
Sorry, thank you very much, Reitan. We have a question from Guido Balsacchi from Argentina.
Thank you, Dr. Ribeiro. Yes, my question is, which step of the technique do you think is the most challenging one? And if you think that there is still place to improve the technique?
I think, well, the pelvic part of the procedure is quite easy. I mean, we all are very used to anyone who is doing a simple hyst handle the pelvic part of the procedure is quite easy. The retroperitoneal part of the surgery, it's the more difficult part. I wouldn't say difficult, I would say more time consuming, and you have to be very careful and take your time and be on the right plane, because you don't want to cause any trauma to those vessels. So more than difficult, it's more like a hard working part of the surgery. That's the most difficult part of the surgery for sure, but still it's something that gyne-oncs will do it easily because they are used to retroperitoneal dissection, so it's not so difficult. And yes, there's still lots of room for improvement, and we have been doing that too. And I have seen surgery from other colleagues, and they also helped a lot to change and evolve the procedure. So one of the things that we now are doing, we are not attaching the cervix at the umbilicus anymore. I know it's kind of awkward having umbilical menses, and most of patients think, well, actually the patients, they don't care, and they are more interested in preserving their fertility. And if you explain them that that's not a problem, that's going to happen, that's good if you have normal umbilical menses. But I know most of the doctors, they don't like it. And actually, it's also time consuming to attach the cervix to the umbilicus. So now we give some Lupron or whatever you want to keep them without menses, and we live inside the abdomen. What happens is they have like a hematocope, more mucocele and other complications, but they are minor, and you just drain, and you have no major complications when you leave the cervix inside the abdomen. And we used to do that because we want to make sure the flap, because the uterus is a flap, had good perfusion. So the best way to do it is look at it. So just look at it, and you can check twice a day if there is good perfusion. So now, as we are more confident about the procedure, we are leaving it inside the abdomen. And obviously, as this is a new procedure, we are seeing small improvements done by different groups. And I'm very happy to say that I'm learning a lot of other colleagues.
Thank you, Reitan. I have a question about the technical issue. Are you still putting sutures and stitches outside the abdominal cavity, or are just using internal suture right now?
Yeah, I still do it. I mean, that's the worst part for the patients. They have their typical complaint is pain on those stitches. They cause lots of pain to the patients. And I'm not suturing. I mean, you can do laparoscopic suture. It's time consuming, takes longer, sometimes it's harder. And one of the things is I don't want to make traction to the ovarian vessels because I do this suture around the abdominal wall. So most of the time you don't have enough length to do it with the abdomen insufflated. So you have to deflate a little bit and then suture, so it makes it harder. But I think that Mario Reitan from Memorial and other colleagues, especially who are doing it using robotics, are doing it with the pneumoperitoneum. I still do it transparietally. And that's the next step I have to move forward probably, and just do it intra-abdominally.
Perfect. Thank you very much, Reitan. We have a question from Jorge Hegel from Venezuela.
Yes. Hello, everyone. Thank you, Dr. Ribeiro, for this amazing article. So my question is, one of the most relevant complications was cervical ischemia in 37%. Based on your experience, do you think there is a way to reduce the percentage of this complication? And what could be the main cause?
Yeah. So what happened is, looking at the video of those patients, we realized that it happened to the patients that when we entered the cervix during the paracervical dissection. So now what we are doing, we are preserving the descending branch of the uterine artery. And now we didn't have any cases of ischemia anymore, of cervical ischemia. And so the cervix looks way more perfused with blood. And we didn't have any more cases of stenosis or whatever. So probably what happened was we entered the cervix, so we could see we getting too deep into the cervix, and then we are losing this lateral vascularization of the cervix. So now what we recommend is to do a little bit more lateral, like a type A radical hysterectomy, something in between the ureter and the cervix, so you keep this lateral blood supply of the cervix. That's a very important point. I think that's something that it's very important to stress about the technique.
Nice, Reitan. It's such a good tip. I have a couple of questions from the audience. One is, where the uterus is transposed, it is away from pelvis. How the vascularization is secure after transposition and after reimplantation?
Can you repeat the question? I didn't get the...
When the uterus is transposed, is away from the pelvis.
Oh, yeah.
How can you assure the vascularization during the uterus is put in the abdominal wall and before putting again into the pelvic cavity?
So what we know is from radical trachelectomy that you can ligate both uterine arteries, right? So that's been done for more than 30 years now. So we know we can ligate both the uterine arteries, and the cases of uterine necrosis after radical trachelectomy are very rare. Obviously, people tend not to describe bad results, but we know it's probably around 1% or less. So we know that the gonadal vessels are enough to provide blood supply to the uterus. That's we know. So the point is, if I keep the vessels coming from the retroperitoneal area, the ovarian vessels, we can keep enough blood supply to preserve the uterus. So now what we do is, after dissecting those vessels, not exactly the vessels itself, we dissect the whole package with the vessels and the fatty tissue. You don't want to dissect those vessels too close, so you just remove this fatty tissue around along the infundibulopelvic and the gonadal vessels. So when we put it in the upper abdomen, usually you can clearly see there is good perfusion. Sometimes you can even see the gonadal vessels pumping blood. But what we do now is we use ICG. So we use intravenous ICG, and in less than 1 minute you have the uterus being perfused. So we are sure we are getting enough blood supply. The other thing we do,
yeah, please.
The other thing we do is in the post-op, we do a Doppler ultrasound. So 2 days after surgery, I'm sorry, Rene, if I'm being, like redundant, but I think that some people are getting into it for the first time. That's why.
No, it's great. It's great, Reitan, having the explanation by you. It's amazing.
Okay, good. So then what we do is 2 days after surgery, we do a Doppler ultrasound. So transabdominal Doppler ultrasound of the gonadal vessels. And at the level of the ovarian uterine ligament, we check for blood flow. And usually it's very easy to find it, but obviously you need some, the radiologist takes a little bit of time to get used to it. But once they got the idea, because for them it's just weird, they don't understand. So once they understand, usually they easily find, because they just find the uterus and they just go lateral. And then you have the gonadal vessels. It's not difficult. But one of the things that we realize that sometimes the blood flow, you don't know if it is just enough, because sometimes they will check for blood flow and there will be very little blood flow coming from those vessels. Is this enough? And actually what we realize that usually yes, so you don't have to do anything with those patients. And even we had a case of a patient who had just unilateral blood flow coming from an ovarian vessel. And you say, well, she may lose her uterus. And actually she didn't. So she had a really good evolution. And when we reimplanted the uterus, it was perfect. So if you have enough blood supply coming from one side, you probably doesn't need to do anything. And then another thing that we used to do in the beginning, now we don't do anymore. We used to do MRIs, so to check, because with the MRI you can see perfusion. So it's very easy to see perfusion during an MRI. And something that if you are not sure about the uterine perfusion, just do an MRI. You cannot rely on clinical examination, because the cervix may be ischemic, so you don't know if the uterus. So if you have some ischemia of the cervix, you may have a good uterus. So I recommend you to use MRI. On the other hand, when you put it back, usually after 2 or 3 months, the uterus has those big gonadal vessels. So you are not afraid of losing vascularization. The only thing is you have to make sure you don't rotate the uterus, because you can, if you twist the uterus, you may cause a block of the blood flow. And And it's very incredible how fast those patients heal and how fast they resume normal menses. And if they have normal menses, they have a good uterine perfusion.
Thank you very much, Reitan. We have a question from Zeta.
Thank you, Dr. Ribeiro, for your exam presentation. My question is, how long and at what dose did you use anticoagulant after uterine transposition and during the pregnancies?
Sorry, can you repeat it?
How long and at what dose did you use anticoagulants after the uterine transposition and during the pregnancies?
That's a really good question. So while you are using a flap, right? And this is a cancer patient. So just for those two reasons, you have to use at least for 20, so 1 month of anticoagulation. And we do it exactly like we do a regular prophylaxis for any major procedure in gyneon. So we use it for 1 month, then we stop it. This was a big issue when we started, because we have this discussion with the vascular team to know if we should use like another agents or for a longer period of time. And they said, well, we do this for many different procedures, and 1 month are usually more than enough. So that's why we do just 1 month. When the patients get pregnant, we don't use any kind of anticoagulant. They just go through a normal, not a normal schedule. They are considered high risk for complications, so it's a high risk pregnancy, but we don't use any kind of antithrombotic prophylaxis.
Perfect, Reitan. Thank you very much. We have a question from Banza. Thank you for interesting study. How can this procedure be implemented in hospitals where surgeon has never done it before? Also, should there be specific criteria for declining patient request for this procedure?
That's a good question. So, declining the procedure, you know what? That's more often than we think. Sometimes I decline some patients when you are not confident of they being able to understand the procedure. This is one of the things. So they need to understand it, because they are high risk for pregnancies. So they have to have this different schedule, and be much more. They need to be reliable, because the thing that you don't want to have a high risk pregnancy in a patient who are, like, doesn't do any of the things that they have to do. But the main reason for declining putting patients on the trial were anatomical changes, like surgery of the ovaries or previous pelvic radiation, or if they need to change any part of their cancer treatment. That's one of the things that, to start the procedure, when we got the approval, one of the first things they said to us is the patients have to do the cancer treatment. So to include the patient in the trial, we said, you understand that you must do all the treatment, and you must follow with all the treatment, standard treatment, and they had to accept it, because you don't want a patient who doesn't do the treatment, the proper treatment for the cancer. You don't want to have a mother with cancer. You want to have the best possible results, especially when you are starting something new. You cannot allow for any deviation of the standard procedures regarding cancer treatment.
Thank you very much, Reitan. We have a question from Giuseppe Cusinella.
Hi, everyone. Thank you, Dr. Ribeiro. My first question is about the point of the pregnancies. So considering that normal uterine vascularization is impaired after the transposition, we can suppose that this patient could be at higher risk of pregnancy complications, such as intrauterine growth restriction. So how can we evaluate that risk without assessing the uterine vessel pulsatility index? And the second question is if you administer cardioaspirin to these drugs during the pregnancies.
that's the most scary part of the procedure. So I wanted to change what I said before. What was the most difficult part of the procedure? It's when patients get pregnant, because you get scared because this is something new, and you don't want to have any complication during the pregnancy, because imagine that if we have something like really bad or malformation, we know it's not related to the procedure, but how bad it would be. Or if the patient had a restriction growth and a very small baby, or very early delivery or something like that. So, but what helped us was the studies from the German groups from the Charité, because those patients are very similar to patients from radical trachelectomy. So patients from radical trachelectomy, we have more than 1,000 of those. Not we, I mean the literature. And we know that those patients, they can have normal pregnancies, or at least close to normal. What we know is from radical trachelectomy is more common to have early delivery or preterm delivery. But if you take caution of, if you watch it closely, and that's why we use the German protocol. I don't know how they call it. It's from the Charité group for radical trachelectomy. They are considered high risk, so they have very often schedule of appointments. We do like all the ultrasounds every month to make sure the cervix has the right length, the baby's having satisfactory growth, and usually we recommend to delivery by C-section at 38 weeks. So we don't want to put the baby on stress during a vaginal delivery or something like that. But we know we can follow those patients without the uterine arteries, or checking blood flow in the uterine arteries. So you can follow those patients strictly, like every month, and then in the last third of after 28 weeks, we do it every week. You can follow those patients, and it's safe. And in this study from the Charité group, they realized that if you follow those patients strictly, they have the same, except for premature delivery, they have the same rate of complication of a normal patient. But you have to follow them strictly. So it's not that you can just, well, come back here when you are 40 weeks. No, you have to be have this schedule and do the delivery at 30. They recommend 37 weeks. We are waiting until 38 weeks because they have a normal cervix. So the chance of premature delivery is not that high.
Perfect, Reitan. I'll try to summarize some similar questions in the chat and my own question.
Okay.
There are publications on women undergoing radical trachelectomy, having intermediate risk factors when transposition has been done, or even patients with cervical cancer with nodal involvement or micrometastasis needing radiotherapy. What are your thoughts on these kind of indications, different to rectal cancer or sarcomas or another pelvic tumors of non-gynecological origin?
Yeah, that's Professor Kelly said that we have opened this Pandora box, and now we have to deal with all these new possibilities and different situations. I think for non-cervical, right, vulva and vaginal cancer, that's okay. If the surgical radiation field is the same, probably doesn't make any difference if you just mobilize the uterus. For vaginal cancer, what we do, we have done that, is we keep the cervix attached to the vagina and we mobilize the uterus like in a transposition. So we keep irradiating the cervix, and also the lymph nodes around the uterine vessels to the pelvis. So they keep this structure, and they irradiate the cervix, the vagina, and all the lymph nodes. For vulvar cancer, I think it's easier. It's closer to a rectal canal anal cancer, I would say, something like that. For cervical cancer, well, now we have a problem because probably this would be the largest indication for uterine transposition. Probably this would be the most common indication in highly selected cases. What I mean by highly selected cases, I mean patients with very small cervical tumors, a very big margin, because do we need 3 or 4 centimeters in the cervix in a patient with less than, I don't know, 3 or 4 millimeters of invasion? Probably not. And in this case, it's probably the more important part of the radiation. It's the paracervix and the lymph nodes. So, or patients like with a micrometastasis in the lymph node and a very small cervical tumor. So we have cases like that reported. And probably irradiating the paracervix and the lymph nodes are the most important part. However, we are not sure that's safe. So we need to be very careful when selecting those patients. And indeed, you may consider that, imagine this situation, you have a small cervical tumor, you have a micrometastasis in the lymph node. Maybe you could just do a lymphadenectomy for this patient and you achieve something like cure those patients. Maybe, I don't know. So we have to explore other options. What I do not recommend is doing neoadjuvant treatment to shrink a tumor and do a transposition. We have many papers with neoadjuvant treatment for cervical cancer, and most of the time they don't end well. So I do not recommend to do. I think we need way more data before starting doing conservative treatment for big cervical tumors. So I think that's a little bit too much.
Thank you very much, Reitan. There is another question from the audience. Do you think that the approach, laparotomy or laparoscopy, may affect the success rate of the procedure?
There's, I think it's easy. It's easier to do it open, laparoscopically.
Yeah.
I think it's easier. The point is you need training, right? So it's a very, very important question, because usually we think with the experience we have, but again, probably most of the world do not have access to laparoscopy. I know it may shock you, because if you are a gyne-onc fellow, or if you are a gyne-oncologist, you probably are in a country or in a place that have access. But half of the world doesn't have access to even simple laparoscopy. So in these cases, yes, I would consider doing it open. And actually, when we talk to the patients about the procedure, we say that we may need conversion to achieve the surgery. And that's another good question, because you may say, if I need to convert to open surgery, should I do it anyway? And I would say, yes, why not? If you need to convert a cholecystectomy to open to achieve what your goals, and for the patient's safety, you should do it. So I think it's okay to do open. I think it's harder, but I think it's okay. You may have more complications related to recovery and to the abdominal wall. But if you have the proper knowledge, I don't see any problem in doing it open. So yes, I think it's possible. Not my preferred option, but it's possible.
Thank you very much. We have a question from Matt Bagger. Matt, you're mute.
Sorry. Thank you so much.
Nice.
So in other literature, ovarian transposition is effective in about 50% of cases at preserving ovarian function when pelvic radiation is indicated. And I'm curious how the addition of uterine transposition affects that anticipated hormonal outcome, and how patients are counseled on this when they're considering this procedure.
Yeah, that's a very good observation, because if you take into account that just 50%, why do we expect to have 90% doing uterine transposition? That doesn't make sense. But I would say if you read carefully the papers about ovarian transposition, sometimes it's not clear how high, how close to the subcostal margin the ovaries were placed. So this is one of the points. And there is a paper, it's I don't remember the author, I'm sorry, but there is a paper saying that when you put the ovaries 1.5 centimeters higher than the anterior sciatic spine, you can preserve up to 90% of the gonadal function. So probably, and I have seen that a lot, and probably you also seen that a lot. Some ovarian transposition, there are more like, you know, just small lateral fixations of the ovaries. So as we have lots of cervical cancer, we have lots of experience doing that. And usually we put it at the level of the tip of the liver. So very, very, let's say, close to the liver, and at the subcostal margin. We usually do not accept like small mobilizations of the ovaries when we are doing that. And also you have to consider that for cervical cancer, usually we use higher doses of radiation than we use for rectal cancer. So this may also have some effect on this. Another point is maybe we are doing it in younger patients. I don't know. Maybe we have better patients. Highly selected patients, because we are not doing, you know, it's a highly selected patient. And also for ovarian transposition in cervical cancer, some patients irradiate the retroperitoneum or the inframesenteric area, and then you may lose the ovaries even after a transposition. So I think those are the main reasons for having had a better result in terms of ovarian function.
Perfect, Reitan. Thank you very much. This is an interesting concept in this question. Thank you for a wonderful study. Could you tell me the optimal timing for transplantation? What are the post-surgery treatment? Is there transplant rejections? My question is there a transplantation or is there a transposition? And can you explain the audience the difference between transposition and transplantation?
Yeah, that's a very, very central question. I think one of the things from transplant is you get an organ from another person and you reimplant in a different one. So when we are talking about transposition, it is all in the same patient. So I just mobilize the uterus to the upper abdomen in this same patient. 2 or 3 months after that, I put the uterus back to the pelvis. So we reimplant the uterus in the same patient. So it's the same patient. This patient always have the same, the vascularization is preserved by the ovarian vessels, and so it's in the same patient. When we talk about transplant, we take a uterus for one patient and put in the other patient. And actually for irradiated cancer patients, probably transplant is not a good option because the changes radiation causes to the pelvis of those patients. So it's a little bit harder to suture in a vessel who have been irradiated, like the internal iliac, which is usually the artery you're gonna use for a transplant. And even the veins are, it's more difficult to work with the veins in irradiated patients. So that's why I think that transplant for those patients usually is not the best option. Also, you have to consider when you use transplant, you need to use immune suppression to this patient. So this patient has a cancer, and we know that the immune system has an important role for treating those patients and maybe for keeping the cancer away, and then you start using suppression. So probably that's not the safest way to deal with a cancer patient. But you can do it later, years later, the treatment. That sounds way better. But that probably using immune suppressant in the cancer patient is not the best option right after or during the cancer treatment.
Perfect. I think it's similar to when you need to put a kidney down in the pelvis due to an accident or due to a trauma. It's just a change of the original location. Uterine transposition is a temporary change of original location meanwhile receiving the radiotherapy, but then you will put the organ in the same place. But this is not a transplantation by definition. It's not a transplantation. And I have another question is, how long will be the hormonal function be back? It is a fast phenomenon. You have to wait some months or whatever.
It's right away. So, and when I mean right away, because when we put those ureters we attach the cervix to the umbilicus, they have menses, and usually they have regular menses right after surgery. And I was expecting them to have like to stay months without menses and stuff like that, because we see that sometime after, like regular surgery, it's very common to the patients to delay the menses and stuff like that. And actually, it didn't happen. They kept normal function even when the uterus was in the umbilicus. But if you use like Lupron or other treatments to avoid menses, then you have the time from the medicine working. So usually 3 or 4 or 6 months, depending on the dose you are using and how long you are going to use it. But once you put it back to the pelvis and you don't have any drugs suppressing menses, they start having menses in, it's like a normal cycle in 15 days sometimes, 10 days sometimes, 1 month, whatever, but they keep those regular menses. And that's very interesting. I wasn't expecting that at all, to be honest. I was expecting them to have delays in dysfunction and stuff like that. Again, those are highly selected patients, so it may happen, may help.
Perfect. There is a question from Hassan Al-Salman. Hassan, can you ask your question? Because I don't understand quite well the question as written.
Yes, thank you so much for this wonderful presentation. Actually, it seems a stupid question, but I'm like to think out of the box if this is possible. My question is, can we transfer the uterus with intact uterine artery? I mean, if we can skeletonize the uterine artery and keep it, maybe to tie other vessels like obturator and other anterior branches. I don't know if this will give us a good space or good length to transfer the uterus. I don't know. I'm just asking. Thank you so much.
You know what you're saying is really interesting, because that's the way of go when we have a different, difficult and a new challenge. What I mean by that is we are so used to think and to tell patients that there are no options. This is the only way to go. This is the only way to do it, or you have no options. And uterine transposition is, I think it's the most important thing, is that we need to rethink surgery. And so many surgeries we are doing in one way, we probably can improve it, or even we can have new procedures. That's not easy. That's not going to happen every day. But what you said, that's a very important question, because it's probably there will be better ways to do it, but we have to try. And if you think about it, what you said, it's very reasonable. I think if you take the internal iliac artery, like the length of the uterine artery probably will reach more than 10 to 15 centimeters. I don't know. You may be able to preserve the uterine artery and do it. I'm not sure you can do it, but that's a good question, fair question. And I think we need to think of different ways of doing it. But for instance, I will give you a perspective of what you're saying. Maybe if you just will need to do a lateral radiation for a sarcoma or something, well, you may just ligate one of the sides and you may rotate the uterus and put it in the other side of the pelvis. It's going to work, as well as transposing like the uterus and stuff like that. So yeah, maybe it will work. Now I think you will not reach the upper abdomen doing that, but I may be wrong. Maybe you prove it.
Okay, thank you.
Additionally, the advantage of mobilizing the uterus with the whole infundibulopelvic pelvic ligament is you include the vein drainage. That is key when putting an organ in another place. Otherwise, you can put or attach the uterus to epigastric arteries, and by microsurgery you can do it. But the problem is the veins. You have to attach the veins, and in fundibulopelvic, you can find more than one vein, most of the time 2 or 3. So it would be put the procedure more difficult that is right now, because you are mobilizing all the infundibulopelvic ligament. That is the reason you had so few uterine necrosis, because the vascularization is enough, as has been demonstrated since many years ago doing radical trachelectomies.
Yeah, that's a good point. I will keep that on mind.
I have room for another question. For cases where cervix is not attached to the umbilicus, is there a preference for what hormonal therapy to start? I think the question means to contraceptive pills or GnRH analogs. What is your preference, Reitan?
What I do is, if the patients are taking anticonceptional pills and they are using it continuously, I just say them, just keep using it. Don't stop it. So I don't like to use like analogs and stuff like that, because I mean, this is a fragile patient going through cancer treatment, and then you put them on menopause. That's what I don't like about it. You know, like they have been suffering a lot, and then you just add something that can be very hard for women. So that's why I prefer using like contraceptives if they are already using it. Otherwise, I would analogs, because I know they work faster, and they'll just, you know, the chances of spotting and having menses are lower. But I think that's something that we will need to figure out the best way to do it.
Thank you very much, Reitan. This has been a great journal club. We have more than 70 people at a time. I would like to invite all of you to put on your cameras in order to take a picture for Twitter and for social networks. That would be great. See all your faces in that picture. Okay. Ro Pasarel from Argentina. Megan, Hale, Esther. Let's proceed. Okay.
Lots of friends.
Yeah.
That's great.
Arthur, ready? Have you already taken it? Perfect. Reitan, again, thank you very much for this amazing journal club. This has been very insightful, and we hope you enjoyed your time with us today. I want to again thank Reitan and all the faculty for their time. I would like to thank all of you for attending the journal. The recording to today's session will be available on IJGC, IJCS, and ESGO websites. Please remember to join us at the January Journal Club when will we discuss the HIPEC complications along the years. Thank you very much. Merry Christmas, Happy New Year, and see you next year in January. Bye, my friends. Thank you very much.
Thank you.